Today we are going to discuss the concepts of pleomorphic adenoma. Now here I am showing you three pictures. All these three pictures depict swelling, one in submandibular region, one in parotid region, one in palatal region. Second most important point is that here the size is very large, here it is medium or small, and here the size is very small. So number one point which we have to remember is that there is diversity. They can range in size and they can be seen in large salivary glands, major salivary glands or minor salivary glands. So we have to remember number one point. The thing is that pleomorphic adenomas are diverse clinically. Not only are pleomorphic adenomas diverse clinically, but they are also diverse on basis of cytomorphology, and there is architectural diversity seen histopathologically. Now, they account for two-thirds of the parotid glands. According to some studies, they account roughly from 65% to 75% of all parotid tumors. And among all salivary gland neoplasms, pleomorphic adenoma are seen in 45% to 75% of the cases. So there is diversity regarding the number, regarding the size, regarding shape, regarding the location, and they are very common tumors. After basic of pleomorphic adenoma, now let us discuss the other features. Pleomorphic adenoma is seen in both children and adults, although common in adults. Histopathologically, three different components are seen. One is epithelial component, one is myoepithelial component, and one is stromal component. All of these three components we will discuss under histopathological findings of pleomorphic adenoma. Important thing here we have to remember that it is also called as triphasic tumor because there are three phases, histopathological phases. Now regarding the name also, there many names were proposed for pleomorphic adenoma earlier. They were called as enchondroma, enclavoma, endothelioma, and benign mixed tumor. But finally, pleomorphic adenoma was considered. The term mixed tumor is used nowadays also, but it is a misnomer because pleomorphic adenomas are derived from only one germ cell layer, that is ectodermal cell layer. Probably it was called as mixed tumor because histologically, in addition to epithelial component, a prominent mesenchymal component is seen. Now let us discuss the term pleomorphic adenoma. Pleomorphic adenoma is composed of two terms. One is pleomorphic and one is adenoma. Pleomorphic, based on histogenesis and histology, both there are different phases, morphological phases, different shapes and sizes seen. The different components are prominent and they vary qualitatively and quantitatively. Adenoma, as we all know, is any benign tumor of the gland. So, the diversity is on the basis of clinical features, histopathological features, concepts of histogenesis, concepts of on the basis of name. There are different names of the tumor. They can be located anywhere in any of the salivary glands. The size range from very small to very large. Histopathologically, ducts, cystic spaces, trabeculae, angular cells, spindle cells, plasmacytoid cells, various stromal components, and also islands, strands, and sheets of cells are seen. Here, there are basically three phases histopathologically, which we will discuss. This is the epithelial phase. This is the myoepithelial phase. This is the stromal phase. Epithelial phase. We'll discuss all these three components later on. This is epithelial component. This is myoepithelial component, and this is stromal component. Here, why I am talking about this? Because the tumor is diverse in almost all aspects. Diverse, and second important feature is it is very common. Salivary gland neoplasm, diverse and common. Now, at the histogenesis level also there is diversity, because pleomorphic adenoma is derived histologically from both epithelial components, which are basic epithelial components are luminal cells and ductal cells, and from the myoepithelial components, which are basically spindle shaped cells, and both of these components can transform in various cells, cellular structures, and particularly myoepithelial component, it transforms in varied stromal areas. So that is why here we use the term pleomorphic. Pleomorphic on the basis of its histogenesis. Pleomorphism on the basis of histogenesis. Also, these stromal changes are seen in mesenchyme derived components. So again, we prove that the diversity of pleomorphic adenoma is on the basis of various histopathological components which are seen both at histology level and at histogenesis level. Regarding the etiology of pleomorphic adenoma, it is unknown. Radiotherapy is the aggravating factor. Regarding the genetic causes, there is genetic translocation between chromosome 3 and 8. We have to remember that pleomorphic adenoma gene is located on chromosome number 8. This gene juxtaposes to the gene for beta catenin, and as a result there is activation of beta catenin pathway, which leads to proliferation of cells. Regarding the etiopathogenesis, the tumor has origin from both epithelial and myoepithelial components. Ragisi et al. Proposed that intercalated duct reserve cell is the progenitor cell or basic cell. Only one cell gives rise to ductal and myoepithelial component, which in turn lead to mesenchymal metaplasia. So, the formation of stroma is due to mesenchymal cells. Ellis et al. They proposed that neoplastically altered epithelial cell is precursor of epithelial and myoepithelial cells. So we have to remember intercalated duct reserve cell and neoplastically altered epithelial cell. They are important in etiopathogenesis of pleomorphic adenoma, IDRC cell and NAEC cell. Regarding the epidemiology, it can be seen in both young and adult. So the age range is wide, but it is more common in 4th, 5th and 6th decade of life. The average age is 43 to 46 years. It is more in females than in males. The ratio can vary from 3:2 to 2:1. And 80% of benign tumors of parotid are pleomorphic adenomas, whereas 50% of all salivary gland tumors are pleomorphic adenomas. Again, these two things are important from multiple choice question point of view. Sometimes the examiner can ask about the range or number of pleomorphic adenomas. We have already discussed the location. They can occur in any of the salivary glands, whether major or minor. Here in this picture, it is seen in tail of the parotid. As a result, there is elevation of the earlobe. And among the parotid glands, these are common in superficial lobe, and 10% of the parotid tumors develop within the deep lobe of the gland beneath the facial nerve. Some statistics regarding the location. They are most common in parotid. In submandibular glands, only 10% of the pleomorphic adenomas are seen, whereas minor salivary glands account for 5 to 10% of pleomorphic adenomas. PPP is the mnemonic pleomorphic adenoma, parotid, palate. Parotid, among major salivary glands, parotid is the favorite location, and among minor salivary glands, palate is the favorite location. In minor salivary glands, pleomorphic adenomas occur in 50% of the times. In lip, only 27% of pleomorphic adenomas are seen. Comparatively less in buccal mucosa, only 17%, and very rare in floor of the mouth and on the tongue. Very rare locations of pleomorphic adenoma are lacrimal glands, breast, mandible, neck, and lymph nodes. The dumbbell tumors are tumors found in the deep lobe of the parotid, and when these extend to the parapharyngeal space through the stylomandibular tunnel bounded by stylomandibular ligament. There are prominent two components seen, that is why the term dumbbell. They clinically appear as masses of lateral pharyngeal wall in the region of junction of soft palate and hard palate, and they may displace oropharynx medially. Clinical features of pleomorphic adenoma in tail of the parotid are they are gradual, slow in growing in size, they are asymptomatic, they are firm in consistency, they cause elevation of the earlobe, the pain and facial neuralgia is very rare, and they doesn't show fixation to deeper structures. Also, they are mobile, particularly during the earlier stages, but as they grow in size, they become immobile. And also, they are in the form of nodules. The examiner can ask a question: which of the following is not a clinical feature of pleomorphic adenoma? For that, you have to remember what are the basics clinical features of pleomorphic adenoma. Regarding the pleomorphic adenoma of the palate, it is dome shaped swelling. It causes difficulty in mastication, talking, and breathing. It is only from 2 to 4 centimeters in maximum dimensions. It is immobile and it is treated and detected earlier than major salivary glands. Now, after removal of salivary gland, the features, there are some distinct features. Major salivary gland tumors, particularly salivary gland tumors of the of parotid, they are covered by capsule. This capsule is many of the times complete, but it can also be incomplete or partial. The capsule or covering, it varies in thickness. The cut surface is hard and rubbery, hard or rubbery, and the color ranges from whitish gray to pale yellow. This tumor after removal presents as the areas of nodular. The nodular areas are seen. These correspond to myxoid or fibrotic growth. That means these are probable stromal areas of the parotid. They account for probable stromal areas histopathologically. We have to remember here, important is that more the number of nodules, more are the chances of recurrence. So the prognosis is not good in these types of tumors. The recurrence is also because of improper removal, mostly by enucleation. What is the reason for that? Because the capsule may be violated, resulting in seeding of tumor bed. This tumor is most of the times incomplete. This capsule penetrates. There are tongue-like projections of the capsule. That means it has got pseudopodia, and there are numerous small nodules. They are called as satellite nodules. All of these factors can lead to recurrence of pleomorphic adenoma. Now coming to histopathology of pleomorphic adenoma. Here, this is the handmade diagram. Now this diagram shows 3 distinct phases. One phase you have to appreciate is this, second area is this, and this is the third one. See here, it is the normal area, normal parotid gland, normal salivary gland showing acini. These can be serous acini or mucous acini. Now this part, the picture is not complete, but this part shows the areas derived from epithelium. Now epithelial areas are of two types. They can be empty or solid. Empty are in the form of duct-like structures, tubules, or trabecular structures. Solid can be in the form of sheets of cells, strands of cells, or islands of cells. This part accounts for shows stromal component. The stromal component can be chondroid, myxoid, or mucoid. This picture shows epithelial component. Now again here this is the modified epithelial component consisting of ducts. These empty structures are tubular structures or cyst-like areas. All these are cystic, tubular, or trabecular areas, and these areas are surrounded by cells which are cuboidal mostly, or they can be in the form of sheets or strands of cells or islands of cells. Surrounding this, there is one more area here. This area is the stroma. There is background of mesenchymal background containing angular and spindled cells. So angular and spindled cells are in mesenchymal background. Here in this picture, the stromal component is prominent. It is a modified stromal component. This is chondromyxoid component, mostly consisting of chondroid areas, and here this component contains small cystic spaces surrounded by sheets of cells. This area shows prominent hyalinized areas. All these areas are eosinophilic areas. All these areas are hyalinized areas. See this eosinophilic area. These all are hyalinized areas. These all are hyalinized areas. Eosinophilic areas, these are all hyalinized areas. So prominent hyalinization, which the more the hyalinization of the cells, the worse the prognosis, and there are chances of more recurrence. In this area we are seeing the sheets of cells, and these are prominent cystic like areas. These are prominent cyst like areas. Here again there are sheets of cells. Coming to differential diagnosis of pleomorphic adenoma, it can be Warthin's tumor, oncocytoma, adenocarcinoma, carcinoma ex pleomorphic adenoma, myoepithelioma or adenoid cystic carcinoma, polymorphous low-grade carcinoma, epithelial myoepithelial carcinoma, and squamous cell carcinoma. The rule of the thumb is that pleomorphic adenomas, they contain 3 distinct histopathological components, and if any tumor contains all the 3 distinct histopathological tumor, then only it is pleomorphic adenoma. Regarding the treatment of pleomorphic adenoma, the superficial lobe is pleomorphic adenoma seen in superficial lobe are treated by superficial parotidectomy with identification and preservation of facial nerve. Now the question asked in exams is that what is the treatment of choice for treatment of pleomorphic adenoma? In that case, we have to answer it as superficial parotidectomy, because maximum of the pleomorphic adenomas occur in the tail of the parotid, that is in the superficial lobe, and treatment of the superficial lobe of the parotid is superficial parotidectomy. If the examiner asks specifically the tumors in the deep lobe, then the treatment of choice is total parotidectomy along with preservation of the facial nerve, and tumors of hard palate which are small, which are not capsulated, the treatment is excision. Now, what is the prognosis of pleomorphic adenoma? The prognosis is very good with cure rate of greater than 95%. The risk of recurrence is lower in tumors of minor salivary gland. Probably they are not capsulated and they are removed en masse. The tumors in lip, buccal mucosa and floor of the mouth can be removed by extracapsular dissection. What are the complications of pleomorphic adenoma? The risk of malignant transformation is less than 5%. It can transform in carcinoma ex pleomorphic adenoma. Now, what are the clinical features of carcinoma ex pleomorphic adenoma? There is gradual increase in size in long-standing pleomorphic adenoma, or recurrent pleomorphic adenomas can show sudden symptoms. Now, what is the cause of formation of carcinoma ex pleomorphic adenoma? The pleomorphic adenomas in submandibular gland have got more chances of developing in carcinoma ex pleomorphic adenoma. The old age, if the tumor is size of the tumor is large, and if there are multiple radiation exposures, the transformation of pleomorphic adenoma into carcinoma ex pleomorphic adenoma are more. The histopathology is similar to that of pleomorphic adenoma, but there is increased mitotic rate of cells. There can be large number of pleomorphic cells, and the hyalinization is prominent. They are classified as intracapsular carcinoma ex pleomorphic adenoma, minimally invasive carcinoma ex pleomorphic adenoma, and invasive carcinoma. Only thing we have to remember is that in case of invasive carcinoma ex pleomorphic adenoma, they are more aggressive, so we should remove them as early as possible. Thank you. These are my references. I hope that this will be helpful to all of you. Thanks for patiently listening. Bye.